everyone, and welcome to today's PHO webinar presentation on orientation to the Urinary Tract Infection Program for Long-Term Care Homes. My name is Lori Schotzler. I am an IPAC specialist at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin, I will mention a few housekeeping items. To enhance the presentation experience, participant audio-video has been disabled. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. So now it is my pleasure to introduce the speakers for today's presentation, Sarah Eden and Eva Skiba. Sarah is an infection prevention and control specialist at Public Health Ontario and a registered nurse who has practiced in IPAC since 2001. She obtained and maintains her certification in infection control designation from the Certification Board of Infection Control and Epidemiology. She has worked in research and hospital infection control before joining the regional infection control networks in 2008. Sarah's recent work has focused on supporting best practices for IPAC across the continuum of care. She has been an author of peer-reviewed research, an invited conference speaker, and is actively involved with the professional association IPAC Canada. Eva joined PHO as an infection control consultant in 2009. She has a degree in nursing and also holds her gerontological nursing certificate and CIC designation. Eva is a member of IPAC Canada and was president of the IPAC Canada GTA chapter. Eva began her career in long-term care in the 1990s, where she acquired extensive experience as both an infection control professional and director of care roles. Eva also worked in IPAC in acute care at Credit Valley Hospital in 2009 prior to joining PHO. Eva has presented at national conferences and at provincial and local events. So thank you, everyone, and I pass it on to Sarah to start our presentation.
Thanks so much, Lori, and thanks everyone for joining today. So for today's session, we have some objectives. By the end of the session, participants will be able to understand the need for implementing the urinary tract infection program, understand the 5 key practice changes that are part of this program. We'll also discuss some potential challenges and successes, as well as discuss some characteristics related to readiness and some considerations for implementation. So Public Health Ontario is a provincial government agency with a mandate to provide scientific and technical advice and support to stakeholders working in government, public health, healthcare, and related sectors. Within PHO, the IPAC program provides healthcare professionals with expertise, support, resources for infection prevention and control. Many of you in long-term care homes will work with a variety of different partners for infection prevention and control. So here's a list of some, but not all of the local partners you might be working with. So some examples with your local public health unit would be things like responding to IPAC issues, compliance inspections to enforce the Health Protection and Promotion Act, outbreak support and management, case and contact follow-up. Your local IPAC hub will provide ongoing support, guidance, and IPAC expertise to long-term care, retirement homes, and other congregate living settings. The Public Health Ontario IPAC team, we've put our email address there if you'd like to reach out. Among the things we do are respond to inquiries and provide IPAC advice related to best practices. And we have both the Ministry of Health and Ministry of Long-Term Care listed here. So if you do have any questions that are related to interpretation of ministry guidance, that is where we would direct you. So now brings us to some of the content for today. The Urinary Tract Infection Program is a program for non-catheterized residents in long-term care homes. So, did you know about 1/3 of prescriptions for presumed urinary tract infections are given for asymptomatic bacteriuria? And then there's a little box at the bottom that does have a definition there. So, what is asymptomatic bacteriuria? It's the presence of bacteria in the urine in the absence of symptoms of a urinary tract infection. So up to 80% of long-term care home residents with asymptomatic bacteriuria are treated with antibiotics. A result of a PHO study of Ontario long-term care homes in 2013 discovered that 50% of results that interpreted bacteria in the urine were in individuals without symptoms of a UTI. And the last message I would really like to share is studies of antibiotic therapy for asymptomatic bacteriuria in long-term care home residents have shown no clinical benefits. So, as you are probably beginning to understand, asymptomatic bacteriuria in long-term care residents does have fairly high prevalence. So 15 to 30% of men and 25 to 50% of women can have bacteria in their urine without any signs or symptoms of an infection. And long-term care home residents have multiple reasons for bacteria in the urine. So there are a number of age-related factors and medical conditions that are associated with asymptomatic bacteriuria. Some examples could be diabetes, pelvic prolapse, enlarged prostate or vaginal atrophy, immobility, incontinence, or dehydration. So there's lots of reasons why long-term care home residents may have bacteria in their urine, but bacteria in the urine without symptoms is not a reliable indicator of UTI. So the problem that does arise is antibiotics are sometimes unnecessarily prescribed for long-term care home residents. So those are residents with asymptomatic bacteriuria, and they may have non-specific symptoms that are incorrectly attributed to a urinary tract infection. So examples of smelly or cloudy urine and nonspecific symptoms, confusion, lethargy, or falls. So really only obtaining urine cultures when residents do have indicated clinical signs and symptoms of a UTI. So additional problem is you can have some antibiotic-related harm. So antimicrobial resistance develops as a result of inappropriate use of antibiotics and is a public health concern. Additionally, if you do have resistant organisms, there is a decreased ability to treat infections, and there would be also an increase in the likelihood of residents being transferred to hospital for IV antibiotics. Other adverse effects of antibiotics could be nausea, vomiting, diarrhea, allergy, rash, kidney impairment, and infections such as Clostridium difficile could also be associated with antibiotics. So while antibiotics are a useful tool, they are not harmless. So it's really important that they are used when they're needed, because inappropriate use can lead to avoidable adverse effects. So there are current recommendations. So routine screening for UTIs and treatment of asymptomatic bacteriuria in long-term care home residents is not recommended. So do not screen urines annually or on admission. And unless the resident has specific urinary signs and symptoms of a UTI, urine should not be cultured and antibiotics should not be prescribed. Some of those key takeaways are in the blue boxes at the bottom. Obtain urine cultures only when residents have indicated signs and symptoms of a UTI and not to perform routine or annual screening on admission. So we know some of those practices do still occur. So why do we continue to follow some of those inappropriate practices, like sending urine specimens without signs and symptoms? So there could be a lack of understanding of accepted UTI symptoms. There could also be uncertainty about urine collection, testing, and interpretation. In some instances, pressure from families. It may also be difficult to ignore a positive urine culture. So if urines were sent without signs or symptoms and you do have a positive result, that may be difficult to ignore. There could be concerns about the consequences of not treating bacteria in the urine, as well as a lack of consensus among practitioners and families about the clinical signs and symptoms of a UTI. So there can be some barriers to best practices. I think some of these barriers are listed here. The first grouping can be, there can be some challenges in assessment. So if there are non-specific things, falls, change in mental function, cloudy or smelly urine, that can sometimes be a challenge in assessment. So really do want to have a very holistic assessment, as well as a lack of understanding or misconceptions about true UTI symptoms. There could also be inaccurate interpretation of urine culture results, fear of missing a true UTI, a history of recurrent UTI, family pressure, or other infections. So as you can see, there are a lot of potential barriers. And one of the goals of this program is really to try to help break down these barriers and implement some practice changes that will align with best practices. So that is what this program is going to be about. And I'm going to turn it over to Eva, who's going to outline the main 5 practices involved in this UTI program.
Thank you so much, Sarah. Yes, so how are we going to break down those barriers? We will do that by implementing these 5 key practice changes. So how this happens in each organization may look ever so slightly different depending on what organization sees their barriers, but the core will be probably the same. Some organizations may focus or want to focus on ensuring everyone knows the correct clinical definition of UTI. Understanding that those non-specific signs, for example, change in behavior, are not necessarily specific to UTI, and also clinical assessments. So are these being done each time? Are they being done correctly? Are we rehydrating for 24 hours until lab results are back? And also other organizations may decide to address specimen collection and transport. So poor specimen into the lab means a poor result from the lab, and how to correctly interpret a urine culture report. So what do these numbers mean when you're looking at the lab report? And there are lots of opportunities to make small changes that will accumulate to make big change and improve the health of the long-term care home residents. Therefore, we're going to implement these 5 practice changes that you see on the slide. So the 5 practice changes are 3 do's and 2 don'ts. So what you would want to do is obtain urine cultures only when residents have the indicated clinical signs and symptoms of UTI. You will obtain and store urine cultures properly, and I will speak to that a little bit later, how to properly obtain urine specimen, and also making sure that it makes it to the fridge in a timely fashion, and you follow your lab requirements in terms of storage. You will prescribe antibiotics only when specified criteria have been met and reassess once the urine culture and susceptibility results have been received. And the two don'ts: do not use dipsticks to diagnose a UTI. And there's actually a really great document as part of this program that will provide you with some resources, especially if you're speaking to healthcare providers who are a bit reluctant and still want to continue to dipstick the urines. You don't perform routine and annual urine screening, as Sarah has mentioned, and also screening at admission if residents do not have indicated clinical signs and symptoms of UTI. So how do we know when someone really has UTI? As Sarah mentioned, clinical definition of UTI is very important, and we are assessing the non-catheterized resident population. Acute dysuria, which means painful urine alone, or two or more of the following. So fever, and that's oral temperature greater than 37.9 or 1.5 Celsius above the baseline. So it's always very important to have that baseline for your residents. And that's on 2 consecutive occasions within 12 hours. New flank or suprapubic pain or tenderness, new or increased urinary frequency or urgency, gross hematuria, which means blood in urine, and acute onset of delirium in residents with advanced dementia. And then key message here is obtain urine cultures only when residents have the indicated clinical signs and symptoms of UTI. So factors that are not clinical symptoms of UTI. So there is specific behaviors that on their own do not indicate a UTI unless clinical symptoms develop. So that's worsening functional status, worsening mental status, or increased confusion, delirium or agitation, change in the urine color, positive dipstick, however, hopefully you're not doing the dipsticks, dehydration, or sudden or increased falls. And also the following factors on their own do not indicate a UTI, and that's pyuria or cloudy urine, fever if non-catheterized, and also smelly urine. So why is assessment so important? First of all, we need to rule out other causes for symptoms. So be aware of any changes of medications, because some medication can actually change the color of the urine or the odor of the urine. Some meds will cause dehydrations and may have adverse effects with other medications or vitamins that the resident is already taking. And looking at dehydration, so as you probably know, the elderly do have decreased sense of thirst. Also, due to cognitive impairment, they may not remember to drink. And depending on healthcare providers, they depend on a healthcare provider to give them a drink, and sometimes they might not even be able physically to drink. They might also be reluctant to drink because they will have to go to the bathroom and they can't make it or don't want to become incontinent. And in terms of urine odor, urine can smell foul, strong, or musty, or even sweet, or like sulfur or ammonia. And some of the causes of smelly urine include eating lots of garlic or onions, having fish or asparagus for dinner. Some vitamins may cause that, also poor hygiene or incontinence. And also changes in the diet. So, you might want to, when you're doing that holistic assessment, you might want to inquire, maybe the resident went out with the family yesterday and they had some red beets or beans or asparagus, and that could be the reason the urine is foul smelling. And also assess for other signs of assess for the signs of other infections. It's important to take vital signs. As I mentioned, taking temperature. Do they have a fever? Is there any change in blood pressure, pulse, or respiratory rate? So those are all important questions or assessments you might need to ask. So the excuse me, this is the UTI program algorithm, and it was developed for assessing urinary tract infections in medically stable non-catheterized residents. So on one side, the left side, the reviews or direct actions for a resident with clinical signs and symptoms of UTI, and the other reviews or direct actions for those residents presenting with non-specific symptoms. And this algorithm is also part of the UTI program, so I would encourage you to take a look, and we have provided the direct link for it. So first, what should I do if I suspect a UTI? So first, the resident needs to have that thorough assessment, and we have been reiterating that quite a few times. And that needs to be done with respect to UTIs. And you also want to encourage increased fluids intake, of course, if that's not contraindicated. So if the resident is found to have dysuria or pain when urinating, that alone is not enough evidence to support sending urine for culture. So, but if the resident does not have dysuria, but does have at least 2 of the signs and symptoms included in the clinical definition of UTI, then urine may be sent for culture. And then if the resident is started on antibiotics empirically, you want to make sure that you collect urine before the antibiotics are started. And this is to assess the susceptibility. And if the resident is presenting with non-specific symptoms, so they're not themselves, maybe more lethargic, you would want to encourage increased fluid intake, first of all. And as I said, unless it is contraindicated, and also monitor for 24 hours and then reassess. And if the resident now meets the clinical definition of UTI, you will want to send a specimen. And if the resident continues to present with only non-specific symptoms, then there is no need to send a specimen or start treatment, but you may want to explore it further why they are actually continuing to have those non-specific symptoms. And when we're reassessing for UTI signs and symptoms after 24 hours, again, if there's no symptoms, there's no need to send urine specimen, and there is no need for treatment. So in terms of testing for UTI diagnosis, urine specimen for culture and susceptibility is the recommended testing method when UTI is suspected. As we mentioned, dipsticks are not a reliable for diagnosing UTIs, and their use is not recommended. And as you know, most residents with bacteria in their urine, even without symptoms, will have pyuria or pussy urine or cloudy, or be positive for white blood cells or leukocytes esterase. And also many residents without bacteria in their urine will have pyuria or be positive for white blood cells or leukocyte esterase. And nitrates are not useful to rule out UTI in or out in long-term care home residents. So again, highlight here in the box, do not use dipsticks to screen for or diagnose a UTI. And just a reminder, as Sarah mentioned, on any given day, if you obtain specimens from all your residents in your home, up to 30% of men and up to 50% of women will have bacteria in their urine without any sign and symptoms. So there is no need to start antibiotic treatment. And when do we collect urine culture? So you would want to collect the urine culture, as we said, only when residents has clinical signs and symptoms, and do not perform routine urine cultures or screen for bacteria in long-term care home residents. And that some of the examples would be on admissions or annually or routinely or even post-antibiotic treatment. So routine and random screening is contributing to the overuse of antibiotics, unfortunately. And again, some highlights in the boxes. So again, obtain urine cultures only when the residents have the indicated signs and symptoms and do not perform routine or annual screening or screening on admission. So how to get a proper specimen? You would want to obtain a clean catch or midstream urine or use in and out catheterization. And working with many long-term care homes in the past, in this program implementation, we saw all kinds of creative practices like using bedpans, hats, or PD bags for collecting the urine specimens. And this, unfortunately, is associated with substantial contamination, and it is not currently recommended. Ensuring that your bottle is properly labeled. So we would include the time and the date, and of course follow your lab instructions, and refrigerate immediately because urine specimens left at room temperature can actually grow bacteria and lead to false positives. And quite often I'm sure you're walking by the nurse's station and you see that container with urine sitting there until the nurse has time to take it downstairs to the fridge. So that's not an acceptable practice. And some of you might think, oh my gosh, this is so much work, the in and out catheterization, or how do I obtain clean catch or midstream urine? But really, when you think about it, because you will no longer be obtaining urine specimens on admission, routinely, annually, that's already cutting down a lot of work, and it will be only some selected residents who are experiencing clinical signs and symptoms that you will be obtaining those urines. So now, how do we interpret microbiology results? And what is a significant result? So bacterial count greater than or equal to 10 to the 8 colony forming units per liter. Multiple organisms, more than 2 different types of bacteria, indicate the specimen was contaminated. So we already talked about the fact that elderly will frequently grow bacteria when there is no infection, and also because it is difficult to obtain a specimen, hence the reason it might be contaminated. Are the organisms susceptible to the antibiotic order? So it's always important to take a look at the lab result and see the susceptibility and communicate that to the prescribing physician. And key highlight, prescribe antibiotics only when specified criteria have been met, and reassess once urine culture and susceptibility results have been received. So when do we treat? Decisions to treat should be based on resident signs and symptoms. Of course, those clinical signs and symptoms of UTI, severity of illness, and urine culture results. So if the specimens are collected based on accepted signs and symptoms for UTI, then the decision to treat becomes a lot clearer. And it's very important to document and communicate resident signs and symptoms. So when you're making that phone call to the physician, especially if it's after hours and you're speaking to a physician who is not very familiar with the resident, ensuring that you have all the information ready and you have conducted that holistic assessment is very important. And please remember, a positive culture alone is not reliable for diagnosing of UTI due to the prevalence of asymptomatic bacteriuria in long-term care home residents. And treatment for asymptomatic bacteriuria in long-term care home residents is not recommended. So the UTI program will provide long-term care homes with a process for implementing evidence-based knowledge and tools, and this is very exciting. And hopefully you will be able to examine barriers to practice changes. Also look at the implementation strategies, so increasing the buy-in and support, because you can't do it alone. You need to have a team that will support you, whether it's a nurse practitioner, physician, frontline staff, not to forget PSWs, because they are the eyes and the ears and they know the residents the best. Maybe your dietitian, physio, and don't forget about the residents themselves and the family members. If you have, strong champions in your staff and family advocates for the program, that will help you to succeed. Also, increasing knowledge and developing skills. So it's very important to educate staff, educate your families, your residents, provide the resources and additional information to the ones who require it, and also use coaching to reinforce practice and support staff. So some other opportunities, you will want to monitor practice and give feedback to staff. So especially if they came up with different solutions and are on board with the program, they also want to get some feedback. They need to know how things are going. Maybe there is a significant decrease in C. difficile infections because you have implemented the program. So those are some of the important and key messages that you want to provide feedback to your staff and residents and families. And continue to remind staff of key practice changes as well. Decrease urine specimen sent and decrease in inappropriate treatment of residents without an acceptable clinical UTI diagnosis, and of course improve resident care. And now, so the key messages for today's session is antibiotics are not harmless, and an inappropriate use can lead to avoidable adverse effects. Only obtain urine cultures when residents have the indicated clinical signs and symptoms of UTI. Obtain and store urine cultures properly, and prescribe antibiotics only when specified criteria have been met, and then reassess once urine culture and susceptibility results have been received. Do not use dipsticks to screen for or diagnose a UTI, and do not perform routine, annual, or screening on admission. And after you, Sarah, thank you.
Oh, thanks so much. I know we have had a lot of great information being shared here, and I see there's a lot of people who have started to think about how they may go about implementing this in their home. So I have a couple of slides that may be helpful if you're thinking about getting started. So we do have a lot of tools on our website, and there are a couple that I would draw your attention to before getting started. So you might want to think about completing the practice change questionnaire. So this will help you understand what are the needs for practice change activities in your home. So this will review each of the 5 practices, and it would ask you to consider if any of the key practices in your home do need changing. So you may already be doing some of those. So it can help you identify what are the specific needs in your home. And that could also give you some ideas about where you might like to focus your attention. And I think another thing to think about before you're getting started, I do have a picture of one of the tools here. This is a resource to help review some of the considerations for readiness. So there's some tips here to help you reflect and really assess if now is the right time to start. So some examples might be, are there significant changes going on in your home or other major program rollouts right now, or would there be an ideal time? You might want to consider who you'd need to consult with to help the program be successful. That could be senior management, medical directors. You would want to think about ensuring that you do have dedicated program lead and the right available time commitment. For homes that are part of corporate long-term care homes, you may also want to consult with your corporate rep about your implementation plans. So some things to think about when you're getting ready. And the next slide has a resource about getting your implementation team together. So Eva previously spoke about sort of a wide variety of people within a long-term care home that you may want to have some buy-in or get involved in order for this implementation to be successful. So there is a resource here about your implementation team that does describe some characteristics of a team and things that may help you be successful. And implementation teams will look different in different long-term care homes. They may be different based on the size of the home and the resources, but there will be some messages to really look for action people. So enthusiastic participants who will be available to help work through challenges and opportunities for improvement in resident care, as well as some tips for thinking about representation from as many key groups as possible. So that could be your lead physician, nurse practitioner, those prescribers, your pharmacist, the IPAC lead, nurses, director of care, frontline workers, PSW. So the list can be fairly large or small, but also you want to consider what would the roles and responsibilities of team members be. So some of those may act as champions. Others could be involved in coaching frontline staff. So the next slide I have here is a screenshot, and there's a link that just popped into the chat of our UTI program page on the Public Health Ontario website. So on this program page, you'll see on the left-hand side, there's a short YouTube video. So it's just about 2 minutes. That's really good at describing what the program is. It might be very useful to share with others within your facility when you're introducing or thinking about this. On the left-hand side is the UTI program implementation guide. So that is a much more detailed guide that walks through all of the different phases of implementation. So if you do want to start implementing this in your home, that would give you some stepwise guides to navigate some of the resources. And across the bottom, you will see there are some tabs there: introduction, assess, plan, implement, and checklist and resources. So within each of those tabs, there are a variety of different resources to support the UTI program implementation. If there are questions, we can maybe refer to some of those resources in the discussion, but things like fact sheet, some evidence information, the algorithm, PowerPoint presentation you could use to deliver education. So there are many resources. I would invite you to spend some time and click through some of those resources to become more familiar with the specific pieces of the UTI program. On the next 2 slides, I have some reference here for this presentation. And then I wanted to end this portion of the session with some contact information about how do you reach the Infection Prevention and Control team at Public Health Ontario, and that is the best address to use: IPAC at
Thank you so much, Sarah and Eva, for presenting. And I want to thank everyone for joining us today. We're at the end of our webinar. You can expect to receive a brief and anonymous survey for today's session. Please try to complete this to help us improve our programming. And you can also expect to receive a certificate of attendance for one IPU for today's session. So watch for that in your email inbox. A reminder to everyone to save the date for topic, the Ontario Public Health Convention that will be held on March 26th and April 3rd of 2024. And you can check out topic.ca for details. And lastly, to access past presentations and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. We want to thank you so much for joining us. Thank you and have a wonderful day.